Hello, I'm Dr. Jenny Andrus, and welcome to Joint Ventures. In this OSC original podcast, we investigate the most pressing topics in musculoskeletal medicine. Osteoarthritis, or wear or tear arthritis, is a pretty ubiquitous human condition. If you live long enough, you're gonna get it. And while we have a lot of good treatments, there are still millions of Americans suffering from osteoarthritis-related pain. Low-dose radiation for arthritis is not a new concept, but with some newer research showing benefit, it is starting to gain popularity as a potential way to treat arthritis pain. So when low-dose radiation therapy started gaining traction, I knew we needed to investigate this more. That's why I'm so excited to have Dr. Abana from Virginia Oncology Associates here to help us understand this treatment better. Thank you so much for coming and taking time out of your day.
Absolutely. Thank you so much, Dr. Andrus. I appreciate the invitation, and it's an honor to be here with you guys today. And my name is Dr. Chike Abana. I'm a board-certified radiation oncologist at Virginia Oncology Associates. I also work with Centera Careplex, primarily out of our clinic over there, and I'm excited to be here to discuss low-dose radiation for osteoarthritis. In our clinic, I work with Dr. Song Kang. He is a board-certified radiation oncologist as well, and we treat primarily cancer patients with radiation therapy in high doses. But we're always trying to advance our clinic and opportunities that we provide. And so we started offering low-dose radiation therapy as a conservative treatment for patients with osteoarthritis, amongst other benign conditions as well.
So tell our listeners a little bit about what low-dose radiation actually is.
So low-dose radiation therapy is the use of very low doses, as the name implies, relatively speaking, compared to the high doses that we use for cancer patients to treat osteoarthritis in this case. And basically, that's in orders of magnitude much lower than you would normally get with cancer patients. So the cancer patient might be getting, say, 30 gray of radiation therapy, but for osteoarthritis patients, we would use only 3 gray of radiation therapy, and that's divided over 6 treatments. So it's a very low dose to essentially destroy cells that are causing inflammation in the joints that we're targeting.
Okay, so the way it works is more anti-inflammatory?
Exactly. So in low doses, that's how we exploit that benefit of radiation therapy.
Okay, so I saw some recent studies on it. What are the improvements that people are seeing with low-dose radiation in osteoarthritis?
So it's essentially effective in controlling pain. Not in everyone. It depends on the degree of osteoarthritis. If it's bone on bone, it's less likely to be effective. However, if it's early stage, it's more likely to be effective. And patients usually realize anywhere from about 20% to up to 90% decrease in their pain score. And the duration varies as well from patient to patient as far as how long it lasts.
Okay, what do you think in your clinical experience? What have you seen the duration typically be?
Okay, that's a very good question. And, we actually just started this in our clinic this year, so we haven't followed our patients for a very long time. But studies that have been published out of Europe, where this has been done for over a decade, have demonstrated anywhere from about 3 months to up to 2 years.
That's a really good duration of benefit. And I know for patients, we want a permanent solution, but when it comes to musculoskeletal degenerative conditions, it's usually going to be something that has to be repeated. Is this something that a patient could look at having done more than once in their lifetime?
Yes, it is. And usually with radiation therapy, we design everything very carefully. It's a very targeted treatment. And so we're able to precisely deliver the radiation to where we want it to and minimize the radiation elsewhere. And with that ability, we can come back and treat the same area that we had treated before. Generally speaking, for osteoarthritis, low-dose radiation therapy, we wait at least 3 months after the first course of 6 treatments before trying again to see if we can get another benefits or if we didn't get any benefits the first time.
Which joints would you be most, or think would be the most amenable to treatment?
Yeah, great question. So generally, joints of the appendages, so shoulders, the wrists, the hands, the hips, the knees, the ankles, the feet, and we can also treat the elbows. I haven't had an elbow patient yet. We generally don't treat anywhere along the spine. Not that it would cause any severe side effects, because these doses are way lower than what we normally give to our cancer patients who do just fine when we actually treat their spine. But there haven't been any published studies, and we're only practicing evidence-based medicine.
Absolutely. Recently, there were some headlines about CT-related malignancies, and that people who have to have multiple CTs of their lifetime, and there was some consideration that that was contributing to an increase in cancer. What would you tell a patient who was concerned about getting radiation exposure for this?
So what I would tell them is, in patients who actually receive high dose of radiation therapy for cancer treatments, the reported rates of malignancies are in the orders of less than 1% over the decade following their treatment.
Wow.
However, and extrapolating from that, with low dose radiation, it's much lower. It is a little bit higher if a patient is younger, and that's why most of the studies done in Europe and most of our patients usually are at least 40 years old. Patients who are about 25 years old would expect about I would say a 1% risk of malignancy, a secondary malignancy, or malignancy from the low dose radiation, I should say, not secondary, because they don't have cancer to begin with. And patients who are 50 years old would expect about a 0.07% chance.
Oh, wow.
And then patients who are 75 years old would be about 0.03% chance. And there's a report out of Germany that investigated patients who have been treated with low dose radiation therapy over a long period of time, and that they were followed, and they discovered no incidents whatsoever of low dose radiation induced malignancy in those patients.
Okay, so especially for the patients that we typically see who are going to be over 40, over 50, that rate seems extremely low.
Yes.
So that wouldn't be a consideration, maybe for a younger patient. Okay.
Yes.
So what populations would you consider this for? If someone comes in, I understand bone on bone arthritis is going to be less likely, but are there specific people that you would think this is probably something you should put in your arsenal sooner rather than later?
Yeah, so it would include patients who have osteoarthritis of the appendages and who have tried conservative managements in the form of physical therapy or medications like NSAIDs, or patients who have had severe intra-articular injections, or patients who are, and depending on the joints, obviously, it could be patients with arthritis in joints that cannot be surgically managed, or patients who don't want surgery, or who are not surgical candidates out of their comorbidities. So there's a wide range of patients that would normally see.
I think what you hit on there with the comorbidities is important. We see a lot of that as our patients are aging. It's not just their joints, right? It's everything else.
Yeah.
And they are poor surgical candidates. And so we do reach sort of an endpoint with a lot of the conservative options. So this is a great thing to kind of add to that stacking of wins. But one question I need to know for myself too is after a patient receives this, is there any limitations on what we should be doing conservative management wise? Should we be mobilizing the joint, or should we be minimizing movement of the joint after treatment? Should we be considering NSAIDs, other anti-inflammatories, intra-articular injections, or should we back off of those things for whatever period of time?
That's a good question. So patients can actually receive any of those managements before, during, or after at any point in time. As far as weight bearing and getting back to like rigorous physical activities, we usually encourage them to just be gentle and take it very easy, because some of our patients realize benefits really quickly while getting radiation, and they get so excited and they want to go back to their normal lifestyle, and we say, well, just take it easy. We have to slowly get to that point.
Okay, what about people who are also doing the regenerative medicine things, like maybe they're doing PRP or that kind of thing? I would imagine that would be not ideal to do those treatments while you're getting radiation. How long should I tell those patients to maybe wait before we consider going back to maybe treating some of the soft tissue issues with PRP or that kind of thing?
I would say generally at least 4 to 6 weeks at a minimum. Until the effects of the radiation have gone off. Now, the radiation doesn't really have any main side effects of concern. if there's anything, it would be some mild redness or darkening of the skin, and those are temporal, usually managed with Vaseline. Other than that, there could be some inflammation going on in response to the treatment that we would just ideally want to sort of like go away before any like injections or any things like that are done to that joint.
Okay, so what does treatment look like? What would a patient experience when they came in for it?
So we would want a referral, first of all, from their primary care or their orthopedic surgeon, and we'll see them in consultation. We'll have a conversation with them, and basically outlining where we want to treat and if they're, if they would like to get treated. From that point on, we would then proceed with scheduling a CT scan. So this CT scan is what we do for everyone who gets radiation treatment. It's essentially how we communicate with the linear accelerator, which delivers the radiation. It is how we tell it where to treat, how much to treat, how large to treat, how often to treat, and where to not treat, more importantly.
Yeah.
And so that will be sort of the next step after a consultation. So we'll get that CT scan scheduled, where we also make devices that we use to immobilize the specific joint that we're going to be treating, because we don't want any movements during radiation, because the beams are fixed. And then from that point on, we proceed with the treatment. It usually takes about a week after we get that CT scan before we start treatment, because we have to do our quality assessments and checks to ensure that it's going to be accurately and safely delivered.
Okay. And then when they go in for a treatment, what will they experience?
And so when they're going for a treatment, they will be in a room with a machine. It's called a LINAC, LINAC. So it's a linear accelerator. It's a big open machine, so there's no claustrophobia or anything like that that will be of concern. And they will just have to lay still on the table. They'll be put in the position of treatment by our radiation therapist. And after the positions are verified, the therapist will step out, they close the gantry door, and then the treatment starts. The beam on time, so when the radiation beam is actually on, lasts less than 5 minutes.
Oh, goodness.
It's very, very short. Before they actually turn on the beam, we obtain essentially X-ray images to verify positioning of the bones compared to the reference point, which would be the CT scan that we got in the first place to plan the radiation.
Are there any patients that I should not refer that would be a poor candidate for this?
So I would say patients who are relatively younger, patients who are pregnant, because we do have anybody who's pregnant, we don't want them to be exposed to radiation unnecessarily, and patients who have tried radiation therapy in the past and have not done well. So if we treated it twice, I generally wouldn't want to treat it a third time. If we treated it twice and it had worked well and we had durable benefits from them, then we could consider a third time, but that would probably be it.
So, kind of circling back to studies on what the improvements are, as you can imagine, in the pain world, it is very difficult for us to really look at studies, right? Pain is a subjective experience. That is the very definition of pain, and trying to chase a pain score it's never going to work. But of course, in studies, we have to have something to go back on. Has there been benefit besides a reduction in pain score? Have we seen functional improvements? Have we seen range of motion improvements? Something that in my mind, those are the things that end up making the patient happy in the long run, unless that their pain was maybe an 8 and now it's a 4.
Yes, we have seen those in studies. As a matter of fact, I've seen those in my patients.
Great.
So anecdotally, I have patients come back while they're getting the radiation, because we something else that they should expect is we evaluate their how they're doing. If there's any side effects or if they're doing better during the course of the radiation treatment. So I've had patients say, I couldn't grab my steering wheel very well. I couldn't bend my fingers, and after just 2 treatments, I was able to do that. It must sounds like a miracle and too good to be true, but that's how you do it. And sometimes they don't quite, know exactly what to expect. And then I ask them, "Are you able to walk better? Is your range of motion better?" They're like, "Oh yeah, I can. I can get out of bed a lot easier. I can squat a little bit, tie my shoes. Things I couldn't do." So those are signs that it's actually helping.
That's way more important in the pain world than a pain score, really, because when pain, I tell patients all the time, when your pain is this, and this is all you can see, and I make it this, at some period of time, this becomes the new this,
Yeah,
you know?
that
And so
is
we're
true.
always trying to chase, our brains are always trying to chase pain free. And it doesn't happen, unfortunately, for a lot of patients, but that functional improvement, if it's durable, that's what makes their life better.
Exactly.
And that's what we're really looking for.
Yes.
So we talked about osteoarthritis, wear or tear arthritis, age-related arthritis. Are there any studies on secondary arthritis, so post-traumatic arthritis, or is there anything on inflammatory arthropathies like rheumatoid arthritis or psoriatic arthritis?
Unfortunately, no. So it's the only studies that we're aware of are studies, on osteoarthritis, primarily, and so I usually let my patients understand that, if you have rheumatoid, this wouldn't help, and I wouldn't feel comfortable treating. I want to have a documented diagnosis of osteoarthritis before proceeding.
And that's going to add to a level of complexity because, of course, patients as they age will often have both. So we have to see, is the RA well controlled? Is this predominantly an osteoarthritis issue? So it does get a little more complex, but hopefully in the future we'll maybe see some more research.
Yes,
Letting us know
hopefully.
which way to go.
Absolutely, absolutely.
Now, anything that I missed that you think that our patients or our listeners need to know?
So, I would say generally it's, radiation, is safe even in high doses. I think um, I guess there's a sort of like a bad rap with
Yes.
radiation, and it's like scary. And what I tell my patients, when they come see me, is the type of radiation that we use is called X-rays. So just like a chest X-ray or a knee X-ray that you've had of that joint, you can't see it, you cannot feel it. You don't know when it's on, you don't know when it's off. Nothing stays inside of you. Anything you do before or after a knee X-ray, you could do before or after therapeutic low dose rate X-rays. The only difference is the dose. It's a lot higher than what you would get from a knee X-ray, but not as high as what cancer patients get. Not even close. And so it's safe, very well tolerated, and it's effective. Now, it's not always going to be effective in everyone. Everyone's experience varies. I tell them not every time you take a headache pill does your headache resolve. So it might not go away. But we're more than happy to try, and we'll certainly take good care of you.
In the pain world, we describe it as stacking wins. It's oftentimes not one treatment that gets us 100% there. Oftentimes it's several things that get us there. And this sounds like a great way to add something else to the arsenal to get patients better.
Exactly. And patients, and I tell them, this doesn't preempt you from getting surgery afterwards if you need surgery. It's just like something else, if you're contemplating surgery, or if you're are not in the best shape for surgery, and you've tried serial injections every 3 months and you just want to try something else, this is something that we could definitely explore.
Would we still expect maybe a 4 to 6 week time between treatment and surgery?
I wouldn't have to wait that long.
Okay.
Yeah, I think surgery can happen, almost, I wouldn't say the next day, but wouldn't have to wait for up to 6 weeks. But I generally encourage my patients to give it some time, because it could take up to 2 months before the effect actually kicks in. So instead of maybe rushing into another intervention, giving it a little bit of time and seeing if it could actually kick in and buy you like a longer period of time before you try the next step.
Yeah, and especially if after a couple months, if it takes maybe a couple months to kick in, and then after that time, doing some of the therapies and some of the other interventions to see if you can then strengthen the soft tissues around that joint, you might be able to push off the surgery a bit longer too.
Exactly.
Okay. Well, how do our listeners learn more about getting in touch with you?
So we do have our clinic is over at Centera Careplex. That's where I see my patients, and generally, we welcome referrals, and we see patients in consultations. We have great conversations and explain everything that we do. We have great staff. Radiation oncology and radiation therapy in general is a very complex field. It's a multidisciplinary field, so we have lots of team members that they're going to meet, but we treat every patient like family, and we do our best to make sure that they have a great experience.
That's awesome. Thank you. I learned so much from this. Osteoarthritis is a complex disorder related to genetics, metabolic, and mechanical factors. Age, injury, repeated stress, obesity, and medical conditions like diabetes all increase your risk of osteoarthritis. With so many people affected, it's exciting to see another option available, especially for people who are not yet ready for or not healthy enough to consider joint replacement surgery. Thank you so much for joining us today. If you learned something, please rate us and subscribe. If you have a headline or topic you'd like us to investigate, let us know in the comments. Wishing you good health and see you soon. Bye-bye.
At Orthopedic and Spine Center, we're dedicated to providing the highest quality treatment using the most advanced technology available. Our fellowship-trained spine and interventional pain management physicians specialize in diagnosing painful conditions and offer minimally invasive interventions to complex spine surgeries. Our pain psychologist helps patients understand and reduce stress from chronic pain conditions. Our experienced physicians get you back to doing what you love. Call today for an appointment. Experience excellence at Orthopedic and Spine Center.